So for those that don't know me, I'm Adam Schulberg, audiologist and managing director of the Wellbeing by Cubex and Cubex Audiology. I'm also delighted to welcome Raul, that's Raul Garcia Medina, who is one of our senior audiologists and a professional colleague with over 25 years experience. I think I've probably known you for the best part of 20 years, Raul. We go back a long way, don't we?
Most probably, yeah.
Yeah. Um, as part of his 25 years experience, he spent 19 years specializing in oral microsuction and cerumen management. So for those of you who don't know, cerumen is wax. Today, we're going to be discussing ear canal health, how to recognize potential problems, how to take care of your ears safely, and also to reduce risks. We're going to have closed captions and live transcription available during this presentation. You can activate this via the bottom bar. Can I just ask everyone just to mute their microphones at this stage? As I said, this session is being recorded. Please switch off cameras and microphones, as I've just said. So just a brief introduction, and then we'll get started. Most people have no idea what's happening inside their ear canals. And let's face it, why should we? We can't see into our own ear canals. And what's more, you may not be immediately aware if something is wrong. We all produce wax, of course, and it's hard to know what is normal and when this might require special attention or treatment and care. But there are other things that we should also be looking out for, and Raul will be discussing some of these things, and we'll also be going through it in our open discussion later on. But for those of you that wear hearing aids, and I think most of you on this presentation today are hearing aid wearers, you'll already be familiar with the challenges that wax ingress can cause, not just in your ears, but into the hearing aids as well. That again is something that we will touch on as to how you can manage this situation going forward. Because it's quite easy to manage with appropriate care. And as I said, we'll be covering this. So a more formal introduction of my colleague, Raul Garcia Medina. As I said, he's an audiologist with over 25 years experience and 19 years specializing in the very subject that we're talking about today. He's also a former president of the British Society of Hearing Aid Audiologists, and he brings strong clinical expertise alongside practical patient-focused care. He's also an associate lecturer in audiology at the Anglia Ruskin University and specialty editor at the ENT and Audiology News magazine. His work focuses on safe, effective ear care, grounded in both clinical practice and ongoing professional involvement in the field. Raul's going to first of all be sharing some information on ear health, conditions, and some risks, and then we'll later provide practical guidance, or perhaps as we're moving along, we may also discuss this. And he's also going to provide some expert perspectives on safe and effective ear care. Raul, if you'd like to take control for your slides.
Sure. Let's see if I can. So give me a second. So, are you guys able to see my first slide?
Yep, absolutely,
Yeah.
100%. Nice and
Well,
clear.
good afternoon, everyone, and thank you for attending today. Thank you, Adam, for the introduction and the presentation. As I said, it doesn't really have to be a talk where you just hear me talking all the time, so Adam will be able to jump in at any point to ask me any questions and to seek clarifications if whatever I'm saying is not clear. I thought I'll start with a basic anatomy and physiology of the actual ear, so we can go back to school for the next 2, 3, 4 seconds, just to actually place the talk in the ear anatomy itself. So we are centering ourselves in the outer ear. So the ear is divided in three sections. As you can actually see from the actual slide, you have the outer, middle, and inner ear. The outer ear is in sort of orange, the middle ear is in pink, and the inner ear is colored in blue. So we are centering ourselves in the actual ear canal and wax productions and cerumen management. But as an intro, just how the actual ear works in itself, and just so you understand how intrinsic this organ is and how complex it can actually be, and how well designed it actually is itself. So, sound goes into the actual ear canal, as we all know. The sound travels through the canal itself. The canal is about 2.5 to 2.7 centimeters in length. It does vary in shape. They all tend to bend twice in the horizontal plane as it goes into the actual head. And then towards the actual end of the actual canal itself, you can see there's a little bit of a dip that's actually created. That's a very characteristic anatomical feature of the canal. All the canal itself is lined up with normal epithelial skin. There is two sections in the canal. The first outer third of the actual ear canal is the cartilaginous part. And then the two inner thirds is the bony part. So you can actually see skin and then little ear and then there's a very there's bone. It's a very thin skin. It's a very sensitive area. The outer part of the canal is less sensitive, and as I said, it's the cartilaginous part. So as the sound goes in, the actual sound travels through the actual ear canal. It makes the actual eardrum vibrate. That vibration is then transmitted further into the ear through the ossicular chains, which are the three little bones in the middle ear, the smallest in your body. The middle ear itself is like a little chamber, and it's an airtight chamber, which is also connected to the back of the nose and the back of the throat via what we call the eustachian tube. And if you remember Euston Station, you'll remember the name Eustachian tube. And this is a tube that we utilize in order to equalize pressure. So the function of that tube is to open and close involuntarily when you swallow, when you yawn, or if you force it open by conducting the Valsalva maneuver, as we call it, which is literally pinching your nose, closing your mouth, and blowing in order to try to equalize that pressure, as we've all experienced these pressure changes on flights and so on. So we want normal atmospheric pressure in the middle ear, same as the pressure outside in the actual ear canal for the membrane, for the eardrum to be able to vibrate freely. Once that vibration is gone into the last little bone, the last one acts as a piston that then creates a little wave inside the fluids of the inner ear. So the inner ear is a fluid-filled cavity, and that fluid that waves itself, travels around the cochlea, stimulating some hair cells. And then there are hair cells there that translate the, if you like, the vibratory energy into electrical impulses that are then sent out to the actual brain via the auditory nerve. So that's really, in a very, very simplistic manner, an explanation on the physiology of the actual ear itself. But as mentioned earlier, we are centering ourselves today in the ear canal and the wax production. So wax or cerumen is actually produced in the first outer third of the actual ear canal, and it's a natural substance. It's a mixture of oils produced by what we call the sebaceous glands. It's also there are some sweat type secretions which are produced by the ceruminous glands, and it's also an amalgamation of dead epithelial skin. All of which is actually produced, as I said, in the first outer third. And it's actually a protective mechanism. Wax in itself is not dirt, despite the misconceptions of the general public or most people. It's actually there serving a purpose. So to actually have wax is actually not a bad thing. To have too much wax to the point that it actually becomes symptomatic, i.e., it gives you a problem, either pain, discomfort, hearing loss, or if a clinician needs to visualize the entire length of the canal and the actual membrane, the eardrum itself, and there's wax along the way, so therefore diagnosis cannot be conducted, then the wax will need to be removed. But for the most part, to have a little bit of wax in the actual ear canal isn't a negative thing in itself. It is true that for those of you who employ hearing technology, the wax can be more troublesome for those who do not. And I'm sure Adam will refer to these later on in the conversation. I've also added some other pictures below just to show you again what I normally see when I look at patients sort of ear canals. When I look into the actual ear canal from this angle into the actual ear itself, you can then see the actual eardrum at the very end. This is a nice, healthy tympanic membrane. You can see it's nice and shiny, it's pearly in color. You can see this here, it's already been drawn for you to actually see it better. But this is the outline of the first bone in the middle ear called the malleus. We can actually see a little bit of the handle of the actual incus over here. This is a light reflex, which is what happens when you actually shine a light into the actual ear canal. And yeah, it's the size of a dime. It's not a very big in diameter membrane at all. Um, so I'm hearing someone talking. I'm not sure if it's to me or as well.
I think that might be you, Jean. Would you mind switching off your microphone, please?
Going back to the wax production, it's being naturally produced in the first outer third. The ear is actually designed to look after itself. It's actually self-regulating. The actual ear canal itself is a microenvironment. It's extremely well designed. As mentioned earlier, the wax is produced in the first outer third as a protective mechanism, but the actual ear self-cleans. In other words, the wax comes out all by itself without you actually having to do anything at all. And it does so via the migration of the epithelium, the actual skin lining the canal walls outwardly. It happens at a rate of perhaps 2 millimeters per week. So I'll say if someone was to, I don't know, put a dot or paint a dot into the actual eardrum, the first layer of the membrane is also epithelial, it's also skin. If you paint a dot in the actual eardrum, I'll say within 3 or 4 months, you'll see the dot kind of almost on the outer portion of the actual ear canal. So yeah, that epithelial migration is like a natural conveyor belt for the wax to be extruded naturally. But also, it produces its own oil. Those oils have antibacterial and antiseptic properties, so it fends off infection. It fends off, obviously, foreign bodies like perhaps inserts or DATs or anything else that may be wanting to crawl itself into the actual ear canal. Um, the the canal itself has a particular acidity as well, which is more acid than the rest of the actual body, again, in order to try and fend off bacteria and ear infections. Very often patients talk about itchy ears, for example, and this is where the skin lining the canal walls is extremely important that it's maintained in good condition. Unfortunately, that's not always the case. More often than not, it is, but sometimes it isn't. And when the skin is a little bit dry and it starts to become a little bit flaky, like you can see in this picture here. So this is the someone looking into the actual ear canal. It's a little bit dark, but this is just focusing on the dry, flaky debris on the bottom right-hand corner of the actual photograph. That's basically dead skin just peeling off the actual ear canal because the skin is actually dry. That in itself causes a bit of an irritation, a bit of an itch, which is extremely annoying. And this can be as a result of very many different things. Some people who is actually prone to just pure dry skin in general. There are also individuals out there who do have some dermatological conditions like eczema or psoriasis, like this. For example, this gentleman's ear appears to have a little bit of eczema. As you can see, all the skin is crackly and it's quite irritated. It's ready. It can actually be a little bit painful at times. It could also be potentially a allergic reaction to certain materials or certain products that have actually gone into the actual ear. But when we start seeing these flaky debris, it actually does disrupt the actual microenvironment that the actual ear canal is. And that sort of flaky debris, if you like, prevents that natural migration of the wax out, because the skin of the actual ear canal is actually just peeling off the canal walls and dropping into the canal, but it's not allowing that natural conveyor belt to take place and therefore to carry the wax out at the normal pace. And that's perhaps the individual that requires potentially some action and intervention by clinicians in order to actually remove that wax. There are different methods of wax removal available. The ones that we tend to favor in this clinic in particular, and I believe in most parts of the United Kingdom nowadays, is called oral microsuction. Different people employ different illumination and magnification techniques. We actually employ a surgical ENT microscope. In my opinion, the best way to visualize, illuminate, and magnify the actual ear canal, so you can actually see what you're actually doing whilst you're actually doing it. And then you employ a little catheter, little vacuum. It's a micro hoover, micro vacuum that actually suctions all the wax out. So it's a very standard procedure. It requires no real preparation. Perhaps putting a little bit of olive oil a day or two before the appointment may help for those of you who actually have a very dry wax. If it's a standard wax, generally, personally, and this perhaps goes against the noise guidelines recommendation, I prefer patients when they don't use olive oil, because sometimes patients can actually use a little bit too much, and it creates too much moisture in the canal. The canal is designed to be dry. Once you start adding too much moisture into the canal, and the moisture stays in there, due to disrupting again that natural barrier of protection. And it's already dark, it's already warm in there. So the moisture is just adding to the equation for germs and bacteria to do what they do best. You're basically creating the perfect environment for infection to take place. So to put too much is not good, because you're softening the wax an awful lot. It doesn't make the wax disappear, it really does just soften it. And sometimes it runs in, it ends up going against the actual eardrum or in the inner portion of the canal, which is a little bit more sensitive to be removed. So if you just leave your ear alone, the wax will be collecting itself in the very outer third of the canal, which is where it's actually produced. That's again the reason why we tend to advise not to use cotton buds or cotton swabs. They were originally designed to clean literally what other people could actually see, i.e. the pinna, the auricle. So all the little folds in the outer part of the actual ear itself. So they were not really designed to go inside the actual ear canal. Anything that goes past the first outer third of the canal is probably not a good idea. So you just want to leave the two or the 2/3 entire ear canal completely alone, because it's self-regulating. It really does take care of itself. This part you're more than welcome to clean, so people cannot point fingers at you and saying that you've got dirty ears. People should clean the little folds in the canal, perhaps even behind the actual ear, that people tend to forget. Moisturization is also a possibility. I tend to advise people to employ non-perfume, non-fragrant, easily absorb moisturizers. There's several brands out there that people will be very familiar with. And literally just to moisturize the actual ear and the very, very entrance of the canal. That keeps the skin in good condition. I think most people who tend to moisturize their face tend to forget the actual ear. In fact, the actual moisturization almost ends just before the ear starts, without realizing that the ear is actually covered in epithelial skin as well. So moisturizing the ear is not a bad thing. Even protecting it, with SPF factor 30 or 50, depending on where you are and how hot and how sunny it is, to protect especially the very top part of the actual ear, is actually very important in order to develop skin cancer. And that's in a nutshell a little explanation about the things that we need to look out for. Here, I introduced little pictures to what a proper Zerumen impaction. Impaction means the canal is completely sealed up. When the canal is completely sealed up by the wax, as you can see here, the sound is not able to travel through it. and you end up with a bit of a hearing loss, which is what we refer to as a conductive hearing loss. There's different types of hearing losses. One is called conductive, and as the name implies, there's a conductivity issue. So there's a blockage in the outer part of the actual ear, or there is an issue in the middle ear. The second type of hearing loss is called the sensory neural type, which is where most of you will fall under. And this is where the cochlea, the organ of hearing in the inner ear, the hair cells in the cochlea, are actually affected. And once they're actually affected, there's no real recovery for that. So that's called sensory neural. We're referring to as conductive hearing losses when there are wax blockages. This is a little perforation of the tympanic membrane. So you're looking at the actual eardrum, and here at about the center, bottom center part of the actual picture, you can see a little hole in the actual membrane. This could have been as a result of trauma by inserting, cotton swabs, cotton buds, or other instruments. I mean, I've heard in the many years I've been doing this, I've heard everything going into the actual ear canal, from car keys to arms of the actual glasses to knitting needles to toothpicks to paper clips, and you name it, pretty much everything. And it's a dangerous thing. I mean, the eardrum itself is fairly robust. It has three layers. It has an epithelial layer, which is the outermost part. This midsection of the actual eardrum is a fibrous layer, and then the inner portion has a mucosal layer. So it's these three layers. So it's fairly robust, but at the same time, depending on what instrumentation once it's actually utilized, can cause a serious problem. This is a more serious perforation. It's more like a central perforation, where you can actually see part of the actual middle ear. So all of this section of the actual eardrum is gone. This is the type of perforation that perhaps will not self-heal. This particular little one may have a chance. This is built perhaps still be on the larger side, and sometimes these needs to be referred on for surgical procedures to actually patch it up. Same as this one. This is the entrance to the canal, and here you can actually see that the canal is actually quite inflamed. In fact, we can't really see deep inside. We can't get to see the actual membrane because the canal walls have inflamed. You can see the reddy parts. You can see a little bit of discharge. There's a little bit of moisture droplets in here. This is a painful ear canal. This is a canal that require rest, require no water, require no hearing instruments, been inserted in there for a little while to allow fresh air and ventilation to take place, and most probably treatment with topical antibiotics or even oral antibiotics in the worst case scenario. This is a more serious ear infection. This is what happens when moisture is collecting in the canal for prolonged periods of time. This is also a painful infection. It's a fungal infection. And you can see the aspergillus, which is the black little dots that you can actually see distributed in there. Fungal meaning, or in relation to mushrooms, fungi. So this is a nasty infection that actually requires quite a long time for it to clear up, and requires obviously antifungal treatment, potentially antibiotic treatment alongside that. Definitely clearance. All of these need to be cleared up in order to allow the treatment to actually reach the areas and kill and fend off the fungus. And that's in a nutshell what I had prepared. I'm now obviously open to more questions from Adam or other people.
Okay, perhaps can you hear me?
I can, yeah.
Okay, lovely. Okay, perhaps I can just lead with a couple of points that you've made there, which are excellent points and a really good presentation. Thank you, Raoul. I mean, likewise, I've also found things like paper clips and matchsticks in the ear canal, which is quite interesting. And on one occasion, what looked like a false eardrum, but actually transpired was a fingernail. Someone actually stuck their fingernail in the ear, and the fingernail had come off, and that was quite a tricky one to remove. But it puzzled me for a little bit as to what it actually was until we got the thing out. You mentioned also about self-management, and of course the ear does manage itself extremely well, and the best thing you can do is nothing at all. And as we say to some of our primary students that we talk to sometimes, The best thing you can put in your ear is your elbow, which always puzzles them.
That still applies,
It still applies, still applies. Even small elbows shouldn't be put into the ear
even.
canals. But of course, most of the people here today are hearing aid wearers and they
Mm,
are putting things into their ears every single day. So perhaps there's not the aeration and ventilation that people without hearing aids might enjoy.
mm.
So this means that the wax and skin cannot necessarily come out from the ear canal as well as it might. So I think some advice around that might be helpful. Certainly on hearing aids themselves, they normally have some kind of wax management system. So with the most common type of hearing aids that we use today, the receiver in the ear canals, this is the over-the-ear style with a wire and a dome or a custom mold. There is normally at the very least a dome on the outside, which should be changed fairly frequently. So we normally advise monthly. It can also be wiped clean and it can be brushed. Allowing it, I think, to dry overnight is normally best practice. If you take the hearing aid out of the ear and immediately wipe it or immediately brush it, whilst there might be some moist wax on there, rather than removing it, you might just be spreading it around. So leaving it overnight will help. Possibly putting the hearing aid into a dehumidifier overnight can be helpful. Although these days that can be a bit problematic because many hearing aids are rechargeable, and whilst they're in the dehumidifier, you can't necessarily be charging them up fully. But underneath the dome, or sometimes instead of the dome, there is nearly always a filter of some description. All manufacturers produce these. They come in different sizes and different types. So check with us or check with your audiologist, and they will advise you on that. And filters likewise would be changed over probably monthly. And that's the advice that we give to most people. Start monthly. If they're coming off clean and you're not seeing any evidence of wax, you might want to prolong the exchange a little bit longer. If they are soiling much more quickly than that, then obviously you need to change the domes and filters more often. But also you probably need to check in with us because it's probably a sign that you are producing more wax or have more wax in the ears that is actually safe and optimal. I think wiping the hearing aid, of course, is great. That will just wipe off any the surface debris. There are brushes and there are other tools that we can provide you with. Something else which is terribly important, which Raoul touched on, is keeping the ear dry. And this is something that's very, very important. And we often advise people, particularly those that are prone to wax, and certainly those with infections or infection prone, to make sure that the ears are kept dry. Now, this doesn't mean having a shower and then drying your ears after the shower. It actually means preventing water from getting into the ear canals because you have this lovely substance inside the ear canal that Raoul described earlier on. And it's almost like it's the skin's own natural moisturizer. And when you get water into the ear, some of this moisturizer essentially is washed out, and you may well produce more wax. And certainly you can get problems with the skin. So keeping the ears dry is key, and we have a special offer for you at the end. In fact, I think we have a giveaway for you at the end, which you might enjoy, which will help with this. Just keep the ears dry if you can. So we have products. There are pharmaceutical products available. I've even heard Raoul mentioning cotton wool with a little bit of Vaseline, just to keep the
You
ear fairly
can.
watertight.
There's definitely different ways, isn't it, Adam? And I think the point that you just raised is very important because since the viewers are definitely hearing instrument users, I think you need to realize also that depending on the degree and type of hearing loss, they use different types of instruments, some of which are more tightly sealing the canal than others. Those who have a more tight sealed canal obviously will get less aeration and ventilation in those ear canals. And obviously, if they have allowed water ingress during the showers and hair washes and whatnot, particularly with all the nice smelling shampoos and gels, can actually irritate the skin even more. And if the water does stagnate in the canal for a little bit too long, and on top of that, you then place the hearing instrument sealing that canal, you almost created like a greenhouse effect going on in there, where the skin of the canal becomes a bit soggy and wet for prolonged periods of time, and then eventually when it dries overly, and that skin then starts to peel, and that causes irritation, and it's back and forth, back and forth. That irritation, that dry skin, then leads to potentially more wax accumulation, higher increased risk of infections, as you said, but certainly the real wanting to go in there and give it a good scratch with fingertips that may be dirty, or as we discussed earlier, with objects that we don't really want anyone to go in there with. So I think it's a very well made point that you've raised there. Cotton wool and Vaseline works very well. It's inexpensive. There are other types. You got some over-the-counter plugs, which works for most people. And then for those who have particular peculiar canals that require something a bit more customized, you can always get these custom-made sewing plugs, which actually require obviously us to take an impression, and then from that impression we send that to the lab, who then manufacture these swimming plugs, for example, which are designed to fit their ears and their ears only, and that's definitely a watertight seal. So you can go swimming, you can have your showers without the risk of allowing water into the ears.
Okay. I just wanted to just touch on microsuction as a procedure because it is the gold standard procedure. It is the safest procedure. I know that sometimes you do also you do employ some manual removal as well for tricky ears or for more complex problems. And Raoul is about the only person that I've seen in our industry, excepting ENTs, that actually removes debris from very deep inside the ear canal, even peeling debris off the tympanic membrane or eardrum, which is so delicate, and he does it genuinely with great skill. And I do have to compliment Raoul. I know that we work together, but whenever I see a patient immediately after they've had wax removal by Raoul, the ear is completely clean, clear, and abrasion free. We so often see patients who've been elsewhere, they've had something done locally, and I'll touch on that in a second. Apart from there still being wax in the ear quite often, there's sometimes infections that haven't been managed and haven't been observed, and sometimes severe bruising, and sometimes bleeding as well. So, the ear is actually, despite all the pictures, it actually is very robust, and it does heal quite quickly. But one does need to be very careful because once you get infections and more chronic conditions, they become much more difficult to manage. But just wanting to just talk a little bit more about how and where one gets wax removed or ears treated at the moment, because I'm sure that most people will have noticed that you can now walk down any high street, and you'll see advertisements in pharmacy windows. You'll see it in opticians, even in some health stores. Everyone is offering wax removal. And clearly not everyone has 19 years worth of experience, and can remove wax and spot these conditions that Raoul has been talking about today. And I'm just wondering about legislation, about training, because it does seem that almost every man and woman and their dog are now removing wax. So, what sort of training is required, and what sort of training is happening, and what sort of legislation is there at the moment, Raoul? Is that something you can just share with us?
Yeah, it's a little bit tricky. It's a bit of a strange landscape out there at the moment, and I think perhaps you need to go back a few years. I mean, microsection has been going on for a good 50 years or so, so it's nothing new. But it was actually reserved for ENT practitioners, mostly in ENT departments within hospitals. What was available to most of us, the general public, was irrigation or syringing, as most people prefer to in GP practices, and that dried out basically. So the GP's services got severely reduced, and I think that was around 1999, I believe. The BMA, the British Medical Association, deemed irrigation not a core service provision by the GPs. So the GPs essentially weren't getting paid for wax removal. So or the vast majority of GP practices have actually stopped doing that, and that has actually lent itself to this new technique in the general clinical area. This technique of microsuction to be uptaken by a lot of different clinical professionals and also non-professionals. And I think that's actually part of the problem. It's very good that it's actually being devolved into the community, in NHS, sometimes within the NHS, but sometimes also privately. But you're quite right to tap into the legislation and the expertise and experience of the individual conducting the actual procedure. I mean, I think microsection itself is not tightly regulated as a procedure. It really depends on who is conducting the procedures, and you have various bodies. You have ENT specialists, obviously, nurses with expertise and experience in ENT clinics. You have audiologists. You have hearing aid dispensers. And you have now pharmacists as well, delving into this world of microsection, all of which have had different sort of training and experiences in this matter, and the quality that does vary, unfortunately, and because it's not tightly regulated, then you have different providers employing different techniques, employing different equipments with different and various levels of expertise. I think you should get guided by your professional organization. I think it's important perhaps that patients look for people who are regulated, who belong to a professional body. Those who actually conduct the procedures should go and abide by the regular professional bodies as well, and their regulations and what is it that they outline and how best to conduct the actual procedure. And yeah, I mean, there are courses that vary between literally 4 hours to months and months and months, which is what I had to go through. I trained in the NHS at the Royal National Threat Nursing Hospital, part of UCLH, and it was a very tedious process. I had to see a hell of a lot of ears. I had to see a lot of people doing the microsection techniques. I had to do it myself whilst I was supervised. And then I had to do X number of years and supervise and document everything and then present it to my mentor. And then I was evaluated on the actual procedure itself. So that took months. But yeah, unfortunately, there's a huge variability. And because it's not tightly regulated, there's some people perhaps that aren't doing it as well as they ought to be done. So you have to
Okay,
be
thank you.
mindful of that.
Thank you for sharing that, Raoul. So I mean, it's an interesting subject, wax, far more interesting than most people think. And I'm tempted to say that we could easily wax lyrical about it, but that would be inappropriate, wouldn't it? But I just wonder if there's, because I'm conscious of time as well, if
Sure.
there are any pressing questions or anything anyone would like to know, if we can just open it up to the floor for maybe 5 minutes or so, and then I can close this lovely session. Any questions from anybody? Long pronounced silence.
Clearly, we've done very well. It's
Yeah,
all extremely clear.
good. Okay. Well, thank you all very much for attending. Inga, can you just head to the last slide?
While that's going on, I think the final line
Yeah.
should be that most ears don't need intervention. Okay. And I think, uh, as I said, they are self-cleansing, they're extremely well designed, but when they do need intervention, safe and appropriate care makes all the difference. And I think that's the bottom line.
Thank you. So
Also, sorry, Adam,
go ahead.
you and I have had cases sometimes where people do think, and I think this is an important point to raise, and it just occurred to me before closure, that people have thought the hearing has gone down because they got a wax impaction, a wax blockage. And they've actually come into the clinics and they actually don't have any wax in their ears. And it could be something more serious than that, right? Like a sudden sensation, you don't hear a lot, something that actually needs further medical investigation. So I think the message is if you are in doubt, if your hearing has gone down, do go and seek professional help one way or another. Don't just leave it. Don't just assume there's a wax blockage. Go and see
Yeah.
someone about it.
Well, it's like to be one of two options, isn't it? It either be just what you've just mentioned, or it could just be that there is a wax blockage in the hearing aid itself,
Absolutely.
which more often than not it is. I mean, when hearing aids come into clinic for repair, I would say that probably over 80% of them are wax or some kind of ingress skin
I agree.
moisture gets into the instrument. And that's why caring for the hearing aid, as we alluded to earlier on, is terribly important. And prevention, as always, is better than cure.
I agree. I mean, if you're wearing hearing aids for sure, but if you're not wearing hearing instruments, uh, you know,
Yeah, seek
maybe
advice.
it is definitely something else. So go
Absolutely.
and have it checked out.
Okay. So, little special offer for those people that are attending. So, you've already qualified for the first one, which is a packet of, they're called Happy Ears. They're made in Sweden. And these beautiful little devices look like a cone. Unfortunately, I don't have access to a photo here, but we have them on our website. And they are probably, they're very, very highly recommended independently, but probably one of the best ways of actually keeping the ears dry, healthy, and safe, and avoiding water. They're also designed for noise protection, funny enough. In fact, that's what they were first designed for. They will reduce loud noise. So at concerts and just in London, it's a very noisy place on the underground, etc. Building sites, people that have difficulty sleeping. So these are fantastic for reducing the impact of noises that you don't want or don't need, and also happen to be phenomenal as something you just keep by the shower and pop them in before you shower or before you bathe or when you go swimming. So you've automatically qualified for some of those, and you can collect them when you come into clinic, or we will happily post them to you. The next offer, as you can see on the screen, is just £10 off your next in-clinic, I guess that's the only way we do it anyway, in-clinic ear hygiene appointment, normally £85. So everyone that's attended today will get. Um, they'll also referred to, sorry, you still hearing me?
You can.
Sorry, I think my voice just went then, did it?
Still okay?
Am I back now?
Yes.
Good. Okay, thank you. They'll also refer to some custom earplugs as well. So for this, we'd make sure the ears are completely clean and clear. So it may actually require wax removal at that point. But once we've removed the wax, we'll then take impressions of your ears. And these are a perfect fit. They're made in a beautiful soft material. So they can actually be worn at night as well. Very, very comfortable. And also they can be worn in the shower or when swimming. And that will also keep your ears totally safe. They are £80 a pair, plus VAT, unfortunately. And if you do need to have impressions for these, then we're doing £20 off the ear impressions. So to have the ears cleaned, custom molds, ear impressions is a good plan if that's what you need. And these offers hopefully will appeal to you. But for any clarification, I'm sure we'll be communicating this by email as well, and can respond to any questions that you might have. Let us know perhaps whether you'd like us just to post some happy ears to you. They come in three sizes: small, medium, and large. And if you do wear hearing aids, we should be able to estimate what might be the best size for you. So just let us know, and we can get those off to you, or you can collect when you're next in clinic. That, for my part, I think just about rounds things off. We are now running regular online events, which some of you have already attended, quite a few of them. And we're looking to have specialists in the field of audiology. And also, we're trying to provide information on access to public services. We did a recent one on Oracast, which I think some of you attended, which is something it's coming. It's coming fast now. And that's going to give people access to sound in theatres, in lecture halls, in museums, airports, railway stations. And we are pushing as an industry to try and get all manufacturers to jump on this and integrate that directly in their hearing aids. There are some roadblocks, but it's now happening, and we're very excited about that, and we'll keep you updated. Also, I think if you have any ideas or any suggestions about any specific topics that you'd like us to cover in the future, then do drop us a message. This is not meant to be a monologue with us telling us what we can do for you or what we can offer you. Please ask, and we'll cover any subjects that you think might be helpful for you and for other people. So I think that's it from me and from Raoul. As there's no more questions, Thank you all very much for attending today's session. We really appreciate it. And thank you very much, Raoul, for giving such a very
Pleasure.
clear instruction and description. That was really helpful and was a good refresher for me as well.
Brilliant.
Thank you very much, everyone. Have a lovely
Take care.
day.
You too. Bye bye.